Well, welcome. Tonight, we're going to meet with some of the people who you don't really see as much as you should for the amount of influence they have on our lives. I believe it's Milford's biggest employer and definitely the group of people who have the biggest impact on our lives, the Milford Regional Medical Center. If I call it the Little Milford Hospital, Ed will yell at me again. So you're going to see tonight a picture of the original Milford Hospital in our trailer. I couldn't resist putting that in. But why don't we start with introductions? Ed, would you lead us off?
Hi, Al. Thanks for having us again. I feel like since we booked this last year, a lot has really happened at the hospital. But again, I'm Ed Kelly, President and CEO of Milford Regional, and I've been here for almost 28 years in different capacities. Started as the Chief Financial Officer, Executive Vice President, President of just the hospital, and then more recently, since 2016, President and CEO. So again, thanks for having us.
Dr. McSweeney?
Yeah, good evening, Al. I'm Pat McSweeney. I'm the president of Milford Regional Physician Group. I've been part of Milford Regional Physician Group, previously Tri-County Medical Associate since 2000. I'm essentially a lifelong Medway resident and have been part of the system for a little over 20 years.
And Peter?
And thanks, Al. I'm the newcomer to this group. I'm the Chief Medical Officer here at Milford Regional. I'm an emergency physician, and I've been part of Milford Regional for all of about 9 weeks at this point. So I picked quite a time to start.
Ed, why don't we start off with an overview of the medical center? Because we hear about what was the physicians group, what is the hospital, what is the foundation board, but most people don't know how they all play together and why.
Sure. So, Al, let me just go back briefly to when I first started at Milford Regional Medical Center. So we were just starting up our physician group, as Dr. McSweeney mentioned, called Tri-County Medical Associates. But we had just affiliated with UMass Memorial at the time. And a big part of that affiliation and relationship was the teaching programs, initially in medicine, and then they expanded to emergency medicine and surgery. So we have residents that come from UMass, as well as a lot of medical students, and so we're a big community site for them. Next, when we recruited these residents, we realized after the first year that they wanted to be employed, and so that led us to the establishment of an employed physician group that Dr. McSweeney now runs. And it's been probably the most important decision our system made was to employ physicians, to get physicians to come to Milford. We also have a number of private practitioners, but in addition to that, what we learned over time is that as a lot of private practitioners retired, we really needed to turn to academic medical centers to recruit these physicians, and so. Over time, we developed a relationship with what's called partners, particularly Brigham and Women's. That led us to the Cancer Center, which brought Dana-Farber and Brigham across the street. As you know, we own the building and have long-term lease arrangements with them. And then about 6 years ago, struck a relationship with Boston Children's Hospital. So we're very fortunate to have have a number of private practice physicians. We also employ a lot of our medical staff through Milford Regional Physician Group, but we also feel very fortunate to have these relationships with 4 academic centers that bring physicians to the Milford area to take care of patients here, which is really the goal. And then if they need a higher level of care, to transition them either to Boston or Worcester, and in some cases, with the specific physicians that are here in Milford. So again, it's day to day. It can be a little complex dealing with physicians from all over the place, but our goal here is to take good care of patients when we can locally, and through all those arrangements, get them all to work together. And I think that's all of that helps to make Milford Regional the special place that it is.
Now, Ed, for a local medical center, isn't it pretty rare to have 4 major partnerships?
Absolutely. We're One of the things that's really different about Milford Regional is the fact that we're independent. And we want to stay that way. And some of that is driven by our geography, because it's not we're all west or all east. It depends on where you live. So I've often said that to have, for a community hospital to have a relationship with one academic center is a big deal. And we've got 4. And, for a lot of community hospitals over the years since I've been here, they've either gone out of business or they've been forced to merge. And that really changes care in the community, because decisions aren't made locally in the community. So yes, to have the relationships with all of the groups that we have is important. And to be independent, I think, is really special for the community in terms of local decision making.
Now, how have you stayed independent? I mean, every year you see fewer and fewer independents surviving.
Yep. So it's a great question, and it's a good lead-in to Dr. McSweeney, because reimbursement and payer rates have generally been flat the last couple of decades. And so the only way you survive in that environment is to grow. And that's really what we've done. Now, you might say, geez, isn't growth more expensive than healthcare? And on the surface, it might seem that way. But the reality is there's too much care provided in academic medical centers here in Massachusetts. And so to keep care local, it's not only convenient for our patients, but it's also lower cost. And again, I think Milford Regional has the best of both worlds. Patients want to stay local, particularly given our geography, but they know that they're getting care that can be provided in Boston and Worcester, often here at Milford. And as I've mentioned before, for if you need a higher level of care, if you need to go to an academic medical center, our connections, our physicians make that happen seamlessly. So for me, it's really a great arrangement for our community. And back to your question, it really comes back to growth and our decision to employ physicians to get them here, because it's not easy to get physicians to come to Milford unless you have kind of all the tools. And an employment vehicle is such a critical tool. And so what we did with our group is we actually broke it out from the hospital. It's run as a real group with its own infrastructure. We work as one system, but Dr. McSweeney leads that. And in his short tenure as president, he's been impressive. I think he really has the respect of all of the physicians in the group, because he's walked in their shoes. And he'll tell you himself, he's been off to a terrific start in terms of recruitment, which is really what our community needs. I mean, one of the questions we get all the time, I get it, is how can I find a physician? How can I find a provider? I want to stay local. And frankly, over the years, it's been a challenge. And it's absent COVID, you would have seen that it's significantly better.
Now, Dr. McSweeney, it's easy to say I'm going to hire physicians, but getting the physicians to want to be hired, I would think, is a bigger challenge. What draws a freshly graduated, or, but I say freshly, by the time they do the undergrad, the med school, the specialty, I think most physicians probably are close to retirement, but what do you offer that brings people to work for you versus hanging out their own shingle?
Yeah, well, I think hanging out your own shingle is getting more and more rare, but I wish I had a simple answer as to what attracts people here, but it's a lot of legwork, and you do a lot of interviews to get to get a precious few. What I always look for is some sort of local attachment, whether it's family or friends or some local tie to the area, because not only do I want to bring docs here, but I want them to stay here, which is probably even more important than getting them here is keeping them here. And so we look for local ties. And I think what's attractive, I think we're a good group. I think I think it's been refreshing to see a group that's run by a physician. and that has a lot of input from its physicians. We have a structure here that we have a lot of input from our physician leaders in the group. And, I talk a lot about that with people that we're recruiting, and they really seem to value the physician input into the way the practices are run. So I would say that's a key component. This year we've been very successful. As I was talking to you off air before we started, in the last 4 or 5 months, we've added 4 internists to the group, and we have 2 new family medicine docs coming within the next 6 months. We've probably hired 6 or 8 primary care nurse practitioners in the past year. We have 2 outstanding neurologists that we've added to the group within the past few months, and again, an outstanding, very well-trained joint replacement orthopedic surgeon who just finished a fellowship at New England Baptist. I'm sure I'm leaving out others, but sort of off the top of my head, those are sort of the highlights for the past year in recruiting. We have more physicians accepting new patients in the group right now than we've had at least in the past 5 to 10 years.
Oh, that's fantastic, because I remember when my daughter aged out, when she hit 26, and they told her, you're no longer a ped. You must move on to big person medicine. It was hard to find somebody with an open practice.
Yep. And in our own group, we have an agreement that in our pediatric practices, kids that age out will be accepted by our adult primary care providers, whether their practice is open or closed. So once we have someone in the practice, we try to keep them in the group.
And could you explain to people what an open versus closed practice is?
Sure. Closed practices, as it's not accepting new patients, so taking care of their existing patients only. And we've had so many docs who've been here for such a long time, their practice fills. Fortunate, a good problem to have is there's more demand than there is capacity historically. So there's more patients who want their care through our group, our docs, and our hospital system than we've historically had capacity for. We really kind of turned that around in the past year. An open practice is one that you can call as a brand new patient and get in to that practice. So again, we have more practices. We probably have, 8 or 9 open practices or physicians right now, as well as probably the same number of nurse practitioners who have open practices as we speak.
Now, Ed talks about the physicians group starting. If you were in Milford back when I was born, you could trace your heritage to 4 physicians. It was either a Capisi, a Mastriani, a Chiquette. You go through the 4, and that was it. You had 4 physicians, and we were lucky to have those. Besides the little Milford hospital, the little hospital that wanted to or could. Now it's amazing. How many physicians do you employ?
We employ over 100 physicians in total, and then another probably 60 or more nurse practitioners or physician assistants. Yeah, it was about 20 or so, 25, I think, when I joined in 2010.
Fantastic. It's amazing to see the growth and how much we can get here now in Milford. Now, Dr. Smolitz, Chief Medical Officer, you joined in the middle of a pandemic?
Is that a question, or are you trying to make me second guess the decision?
I love the idea, but for somebody so intelligent, I got to ask, was that the right time?
Yeah. Well,
Yes.
I appreciate Pat saying that. I'm just grateful that I've been able to contribute to this team during this really challenging time. As an emergency physician, I have lived and breathed this pandemic from the front lines like many other providers, and also have been helping from an operational perspective. So it has been a challenge. It will continue to be a challenge. But every single day that I show up and meet with our team, we're always thinking about how can we better prepare? How can we better plan? How can we keep our patients safe? How can we help to support our providers all across the board during this time? So, you nailed it. This has been a real challenge, but I'm just grateful to have joined such an amazing team at this hospital that's allowed us to really contribute to this community who is suffering through this pandemic along with us.
Well, it amazed me when Ed said he was going to lead an effort to do the new wing, the new Taj Hopkins in that area. And when he said, well, we need $25 million from the community, I remember us looking at him saying, okay, is this a failed attempt at humor? You're going to raise 25 million from the people in Milford? I said, when I grew up, you could have bought Milford for 25 million. They would have thrown in Hopedale and Mendon. But it's amazing. Everybody came through.
Yeah, you know, it dovetails to what you were mentioning earlier and what Ed and Pat talked about. Before I came here, there was an emergency physician who used to work here who described Milford to me, I think the best of anyone, who said it's a diamond in the rough. And over the 9 weeks I've been here, I've seen that loud and clear. For many, many years, the ability to provide really top-notch quality care to a community has been just something amazing to see. And I'm really appreciating that in the short time I've been here.
Now, explain to people what a chief medical officer does.
Well, I guess that depends on the day. No, it is, you know, I see myself sort of as having a responsibility for all of the medical care we provide within our hospital system. I know that's a broad definition, but having that definition allows me to really make sure that I'm focused on the number one most important thing, which is the delivery of healthcare in a real quality way to all the patients that we serve. And that can be very broad in terms of what my day-to-day responsibilities are. But I think that sums it up, is I view myself as responsible for the care that we deliver to our entire community.
Let's take a sidestep. The care we deliver. There's a bit of a pandemic going on. How is Milford Medical Center faring against this pandemic?
It's a hard question to answer. What's that?
I said, who wants to take that question?
Yeah.
You know, it might be helpful just to talk about the difference in the two surges. And by the way, Peter at least joined us in between the surges, so he could catch his breath just for a couple of weeks. But I'll just start off, and the COVID-19 has impacted us not only at the hospital but on the outpatient side. But maybe just to talk at a high level. You know, the first surge was very different. You know, we prepare for disasters. We built space out next below our garage to take overflow from the ED for fast track. So we were gearing up. And what we saw with the first surge was very, very sick patients in our ICU. The elderly, we saw breakouts in nursing homes and skilled nursing facilities. The state had a shutdown, and so most of our outpatient services and elective services were shut down. You would walk down to the ED, and it was a ghost town. So it wasn't what we expected initially. Again, you know, I think the same on the outpatient side. You know, Dr. McSweeney didn't mention, but you know, we have 4 critical urgent care centers that weren't very busy in the first surge. And again, that's a little bit of a look at history to set the stage for, I think, what we're dealing with right now, which is the second stage, which is just so dramatically different. And so I'll let Peter speak to the hospital side of that, and then Pat speak to the outpatient side in terms of what's happening. And again, it's really a system approach to deal with unprecedented time. So, Peter.
Yeah, thanks, Ed. I think there's no easy way to really highlight how challenging this phase of the pandemic, or this surge of the pandemic, has been on our community and on our hospital. And I say it using those two words, community and hospital, because clearly it's the patients that we serve that are suffering the most from this. It has hit Milford hard and surrounding communities very hard. For a number of reasons that we could probably get into for hours talking about. But the reality is that has meant that, as opposed to the first stage or surge of this pandemic, where we had some very critically ill patients, but overall the hospital itself wasn't overloaded with patients or over capacity. At this stage of the surge, or until very recently, we had real challenges with many patients needing admission to the hospital. We were up to a point where almost half of our beds were filled with patients with COVID-19, many of whom were very sick. And at the same time, we've been stressed because staff have not been immune to the pandemic either. Staff have gone out sick, and that has meant that there's been challenges of staffing the beds that we need for these very patients. So we've had to be very nimble, support our staff, support our patients, come up with strategies that would allow us to extend our capacities. For example, we recently had to add 2 additional ICU bed capacity because we just did not have enough space for all the patients. So it has been challenging. Thankfully, we've also had some real collaboration with our region and state through DPH that's allowed us to really coordinate across hospitals to make sure that everyone is getting the resources they need. Still major challenges, but I think we're really managing this with the help of everyone in the institution.
This is a very simplistic question, but how do you decide who gets into the hospital and who doesn't?
I wish that was a simple question. These are challenging decisions that are made on a day-to-day basis by emergency physicians who are deciding based on a number of clinical factors who needs to be in the hospital, generally based on patients' comorbidities, how sick they are at the time of presentation, their vital signs. So when we believe it's needed and safe to keep patients in the hospital, that's what we do.
Now, when you say comorbidities,
it means other types of illnesses they have. So diabetes, for example, or obesity or high blood pressure. We refer to those as comorbidities.
But Tony, an old Holy Cross boy who good, he was there before me. So I respect a lot of what he says. He said there were 4 major comorbidities. I knew because I got thrown out of work when they said I rang the bell on all 4. But, they said diabetes was a big one. Heart disease was a big one. Age. Is there one that overwhelms the others, or is it all a mixture?
It's a good question. I think that's still an area of study, to be frank with you. There are some scores that people can look up that calculate patients' risk for a bad outcome based on the number and types of comorbidities. But to my knowledge, that still is a bit in kind of an investigation stage, and there's nothing that would point to one specific comorbidity that really would highlight patients' risk.
Yeah, I remember I was in the lab when Tony came out and said, 1 is diabetes, 2 is if you're old, 3 is if you're rotund like I am, and 4, is your age. Everybody looked at me and said, you just rang 4 for 4. You're banished from the office. Go home. So, you get nervous, but is there anything I should be doing as a quad ringer? Somebody who rang all 4 bells versus somebody who isn't?
You said it right, Al. Go home. I mean, it really lowering your risk as best you can by limiting your exposures to others who could pass the disease on to you is the key. And the key is the same whether you're healthy or whether you have lots of comorbidities. It's the same. It's social distancing, it's mask wearing, it's hand washing, it's good decision making until the vaccine, and the vaccine, I'm sure we'll get into vaccine talk in a little bit. I hope we do. But, that's the light at the end of the tunnel. And, certainly when your turn is up, and yours sounds like it'll be fairly early in the course of it being your turn to get the vaccine. But, the vaccine is the answer, the long-term answer. The short-term answer is, stay home as best you can.
Now, it seems like, Patrick, that masks are a good thing. No matter what kind of masks, we're silly if we don't wear them. Is that safe to say?
I think that's a very simple and very correct way to say it. There are some masks that are better than others, but masks work. We have lots of evidence in the hospital, in the outpatient setting, people exposed for long periods of time, staff to COVID positive patients who aren't coming down with COVID-19. It's because they're wearing their protection appropriately. And I think that's the key to the message to the public is wear your mask, wash your hands, and stay away from others.
I tried for a while wearing N95 masks. Those seem, I know why they work. They came on my face like something from Alien. There was, it was just applied. Then I saw the KN95s. And then, of course, the little cute blue ones. And then I got the cloth one from Holy Cross. So does it really matter which one I wear?
Peter,
I'll be happy to answer that one. I would not recommend that you or anybody else that's not in a healthcare exposure wear an N95 or a KN95. The science is pretty clear that just wearing a face mask or a surgical type or procedure mask is totally safe and sufficient. It brings us back, the only reason why there was some controversy over the masks at the beginning was because Tony Fauci and others were trying to conserve masks for healthcare. We're now at a point where we have sufficient supply of masks for healthcare. So to reinforce what Pat says, whether it's a cloth mask or a procedure mask, that is of fundamental importance. It's not controversial. And the things that the public can do to keep safe and keep from getting sick are just that simple. Use a mask, keep social distancing, avoiding travel when unnecessary. Those are the things that put people at high risk. And we want to keep people safe. And to keep the hospitals from becoming overwhelmed, we need to keep all of the public safe and not sick.
Well, I remember when Mike Newstein came on to talk about the first viral issues we had. It came down to very simple: wash your dang hands. He had all the perfect technical medical terms. And I looked at Mike, I said, isn't it just wash your hands and limit your exposure?
Well, keep in mind now for this virus, it's a little different. Now, washing your hands is still really important, but what we call the fomite transmission, meaning the surface transmission of this virus, is we do not think it's really as substantial a component of the transmission as like people coughing, sneezing, we call aerosols or droplets. So that's the reason why for this particular virus in this pandemic, wearing the mask and socially distancing is probably the most important safety precautions that people can take.
Now, when I'm wearing a mask, am I protecting you from me more than I'm protecting me from you?
You really want to get into the controversies of this, don't you?
Well, these are the things that at the water cooler you hear.
Yeah.
And
there's probably a component of both, just to be clear about it, right? So when you're wearing a mask, you are protecting others around you, because when you're speaking or singing or coughing, right, those aerosols, those droplets aren't getting out through the mask as much. But we also know that wearing the mask probably prevents roughly, and I say roughly because the science is still not totally clear, 80% transmission of aerosol droplets coming in through the mask. So there's probably a bidirectional benefit to both the wearer and the person that you're kind of facing towards.
But now, if your spray is catching my mask, now I'm trapped. Whatever contaminants you had on the outside of my mask. How do I clean it? Or how often should I clean it or get rid of it?
Pat, you want to answer, or do you want me to keep rolling?
Go ahead.
All right. Well, I guess it depends on the mask, right? If you're wearing a procedure or surgical mask, you throw it away and you get a new one. That's simple. And just don't lick the outside of the mask while you're at it. If you're wearing a cloth mask, you wash it. And the hot water and the soap should clean the mask. I think it's probably just that simple. And just be careful how you're managing or handling the masks, right? When you're taking a mask off, you're not pulling it off by that front part of it and then touching your mucous membranes. And you're washing your hands in between, of course.
That would kind of defeat it. Let me see. I'll just take this and rub it on me.
Yeah, don't do that.
Is it safe to say pull it off by the strings and don't touch the front no matter what?
Absolutely. Absolutely.
Hey, Al, I don't want to lose track of, part of the second surge at the hospital has been at times incredible, capacity at capacity. For us, the peak happened within the last couple of weeks that we had 64 positive COVID patients. We had like 25 patients in the ED waiting for beds. that just goes to show like how full we were really in at the tipping point. But one of the things that really got us through, besides all of the work at the hospital, was what happened over at MRPG in terms of urgent care. And again, it wasn't that long ago. We didn't have urgent care. We didn't have the new building. And maybe Pat can just speak to the efforts there, because they too were heroic in terms of keeping patients out of the hospital, which really helped the system and the community.
Yeah, thanks, Ed. So I think to get a full picture, you need to go back to the spring when during the first surge, just like the ER, the urgent care sites were very, very quiet. The least busy they had been since we opened them. And it was people were afraid to go anywhere, and certainly afraid to go to anything related to medicine or healthcare environments. And then, of course, we converted in all our outpatient sites to telemedicine for a number of months. But as we started bringing patients back into the office, we made the decision that we were going to send all our patients who had any potential for COVID-19 that we could identify through urgent care, and keep our other sites, both primary care and specialty care, as free of COVID-19 as possible, so that patients would feel comfortable and confident coming into our offices for all of their other chronic and routine care. And that's worked well. Our numbers are back close to historical numbers, but our urgent care numbers are through the roof, where we're at 250% of our normal urgent care visits for the past month and a half. And so really the staff at urgent care, the providers, the staff have really, their shifts are 100 miles an hour from the time they open to the time they leave. And we've had both staff and providers floating from other areas of our group to urgent care to help out. So it's really been sort of, as Ed said, heroic, the amount of work they've done. Unfortunately, we've had long waits at times, but still, we've been seeing 250 to 300% of our normal volume in urgent care.
Now, do you try and segregate asymptomatic people from symptomatic people? Is it like go to Hopkinton if you have COVID, go to Milford if you don't?
Right.
I shouldn't pick on Hopkinton, but
we did that initially when the numbers were smaller, but now the numbers are so great that we feel like we've been unable to do that. Despite that, I think we've done a great job at those sites of making sure that we're distancing patients, not having a bunch of people waiting in waiting rooms, cleaning between rooms. Our staff adheres to policy for cleaning and wearing their own protective equipment. We replace cloth masks with surgical or procedure masks when any patients enter our urgent care sites. So we haven't had the luxury of having some sites be just for COVID and others not, because of the sheer volume. For someone from Northbridge to go to Franklin we didn't want people to not get the care because of the distance they need to travel. So we made the strategic decision once the volume got to a certain point that we needed to have all our urgent care see both COVID-related and non-COVID-related patients. And by the numbers, patients have sought the care when they've needed it appropriately.
Okay, now I'm going to make Ed mad. The question for Ed: vaccine. Everybody reads about them. So are you going to get 28,000 vaccines and inoculate everybody in Milford?
Probably not, but we are waiting for the state plan to come out. It's been announced that big centers like Gillette and Fenway are going to have like the significant throughput to vaccine the community. We will definitely play a role in that. We are talking to the state about, we want to be helpful to our community, want to service our community, but we're waiting on instructions to do that. So we're going to do everything that we can in our part to help the vaccines get out. So
now the $64 question: who gets the first vaccines?
Well, Peter handle that. There is criteria from the state of how that is distributed. So,
Yeah,
Okay.
and just to
Sitting here, I'm a 64-year-old with 4 comorbidities, and I sit there and say, when do I go to the top? You know, when is my situation? Or if I have one comorbidity, how do you put together a list?
you missed it by a year.
to answer that question, Al, to answer the question, I would just say your people that are watching this should go to the state's website. I had it in front of me earlier, so I don't remember the exact link, but if you look it up on any web browser, you can find a link to actually what the state's distribution criteria and the phases are, along with a timeline for that. So it goes through, I think there's 3 phases to it, starting with obviously those within healthcare, frontline healthcare workers, nursing home patients, and then proceeding from there to kind of, other frontline workers, essential workers, patients over 65, especially those with comorbidities, and then the general public. And you can find that all on the state website.
But how do you think that's going to play out? We're in January.
I think it's going to be challenging, Al. Our offices are already getting inundated with phone calls from patients asking about the vaccine. We've posted information on our website. We've sent out blast messages, but understandably, the public is anxious to get the vaccine because that's the solution to this. But what I would do is I would plead for patience and essentially waiting your turn in line for your number to be called. Right? We're going to do our best to follow the state's guidance on who is in the current phase and who is the next phase. And instead of being further back in the line and pushing the line closer and closer, to the stage at a concert where the people in the front row can't breathe because they're getting pushed from the back, I would ask for patience from those who are at lower risk that your time will come and you will get your vaccine. But there are people who are identified as being at higher risk of worse outcomes who are ahead of you. And, please recognize that and be patient and understand. There is some challenges to it because there are some groups that are, from our point of view, very difficult to identify. There are many occupations that, the DPH or the CDC has recommended should be getting vaccine before, say, people under 65 with one comorbidity. And I think it's going to be a challenge to identify and confirm that people who are coming in for that vaccine, in fact, fall into those occupations or work environments. So it's going to be a huge challenge for us. And again, I would plead for patience from those who are a little bit further back in line to not trample the people at the front of the line getting to the vaccine.
Well, I think you've hit it, that we all want it yesterday. We all in our minds should be the first ones to get it. But realistically, I think a lot of people are just wondering, okay, if I'm middle-aged, relatively healthy, is it going to be April? Is it going to be June? Is it going to be September? Any feeling for when I should start looking if I'm right in the middle?
You may have to bring on a higher level person with the governor or something on this show for that answer.
Al, as you know, Al, supply of vaccine is a primary issue. But then the site, what we're learning here is that you have to wait at least 15 minutes after you receive the vaccine. Therefore, as a practical matter, in terms of social distancing, these are not going to be able to be given out in CVSs. Even for physician offices, they're going to be a challenge. There's just not enough space. And so I have kind of faith here in our society that we don't know the plan right now, but we're going to figure it out pretty quickly. And, I think what our state is thinking about is starting at a smaller level at a big place like Gillette, and then massively ramping that up. And they're going to learn from that, and they're going to be able to figure out how and where they can duplicate that to get really kind of mass production. And I think they're going to turn to every industry, including our own industry, for resources that can help. So once we get the vaccine, we want to do our part to make sure our community broadly gets the vaccine. So there's multiple parts, and I think honestly, sometimes you have to have a little trial and error, and then you figure out what's working and what's not working. So I think patience is the key, and honesty is it's not completely figured out at this point. And we'll all learn from each other in terms of other states as well. So.
And the only other thing I would add to that is I'm really grateful that we're having a conversation about how to get more vaccine out to more people, because what that means is that there's demand for it. But I still know that there are going to be some people that are questioning the safety of the vaccine. And I just want to kind of state that the studies that we have on the vaccine, specifically the Pfizer and Moderna vaccine, show that it is highly effective and very safe. And so people need to feel comfortable with the idea that these vaccines are indeed very safe, have been studied, and we've seen their safety. So I hope that demand for that continues high, meaning that people want this and that they absolutely, know that these studies demonstrate the safety thus far.
Well, if anybody in my mind, and this is only my opinion, has any doubts, if you're not just a basic anti-vaxxer, that it's going to create 3 heads and 4 legs or something, just looking up the data on the internet should bolster your opinion. It should make me feel safer versus, okay, I'm a rotund old man that's got diabetes. I'm not going to take the vaccine. Well, what are the odds that I'm coming out of this unscathed?
The disease is a lot worse than the vaccine, that's for sure.
Yeah.
And remember that, again, the message as we try to prioritize who gets the vaccine first, the primary goal is to prevent deaths from COVID-19. The secondary or tertiary goal is to get back to a sort of normal society, where we're mass vaccinated. But the first goal is to get the people who are at the highest risk of having bad outcomes protected, not those so that they can travel freely again without a mask.
Pat, if I'm sitting there and somebody offers me the vaccine and there's an elder who's at much higher risk, I got to take a step back. Just out of common decency. If it was my mother or somebody else's mother versus me, how could I take a step forward? I'll growl about it. I'll tell Ed he should have bought more vaccine. But at the end of the day, we're human, and this is our little town, and we'll have to take a step back and say it's not my turn yet.
Yeah, and we think your turn will come fairly quickly. According, you asked the question that we were kind of dodging, but the information we're getting from the DPH is April to June for average risk people to be getting the vaccine.
Now, Peter brought up this idea of more people covered. We're reading a lot about should we give 1 dose and get 50% on 2 people, or give 2 doses and get 95% on 1 person. Anybody willing to take a shot at this one?
I think that's a question where there you go. No, it's a question that I think we're all trying to answer, but the way that I've heard it framed best by the incoming administration, by Tony Fauci and others, is that the aim is to get everybody 2 vaccines. That has to be the aim. And I don't think we'll accept anything less. All I can say from a science perspective, from what we know, is that after getting the first vaccine, or shortly before getting the second dose of it, the effectiveness is about 52%, or 50% roughly, and about 95% after getting the second dose. So clearly our ultimate goal has to be getting people both vaccines.
And I think the idea, Ed, we're putting it all on your back, but if I have to trust somebody from the state at Gillette or the Milford Medical Center, which is always taking care of me and my family, boy, I hope I can get vaccinated in Milford, because it just feels better, feels safer.
Well, again, we want to do what's right for everyone, and we're willing to do that part. So we hope that plays out. Al, you had touched on something just a little while ago, but it wasn't that long ago. Just think about this, 2015, when we didn't have the Me and Family Pavilion, and we didn't have the urgent care centers that we have, and how scary it would be to think back and to have our old emergency department or not have these urgent care centers. It really wasn't that long ago. And if you think about, you started to say, when we looked at our new building, we had sort of the small version, the middle version, and the big version. And you're right. We laughed when we said, how much would that first one, the big one, cost? $50 million. And people just said, like, we'd have to fundraise half of that, and Kevin Meehan came forward and said, I like the big project, and if you go for that one, I'll give you $5 million. And we just kind of took off from there. And we look back now and say, oh my gosh, thank goodness that we did that. At our peak during this second surge, we had 90 patients in our emergency department. We have 50 rooms, 90. I mean, think of that in the old.
How many rooms do we have in the old one, Ed?
I think like 17, I think.
Yeah.
And again, I want to credit our community because they're the ones that said, hey, we'll support you. And they supported us financially, $25 million. And, we kind of talk about that, about having a nice hospital. But if you put it in perspective of this pandemic, it's been incredible. And again, I want to recognize the urgent care centers, because they really held the floodgates back. And, in terms of coming to the emergency department. So really taking the pressure off, trying to take care of patients on the outpatient side, being I think Pat described 250% of what they normally, we had planned to kind of do. It's incredible. So, I often compare, healthcare to sports teams, but it was really a team effort throughout our system that took care of all of this. So again, I in part credit our community for having the support and the vision to help us build what we actually needed.
Well, you bring back a memory, because before we had the new emergency building, I remember that, you had somebody get hurt, and if they weren't critical, they went on a bed in the hallway. And that hallway seemed to be more rooms than fixed rooms.
It was.
I can't imagine what would happen now, where we would put them. I mean, you made a garage into a hospital. That's amazing.
Yeah.
That really is a testament to what we can do as a community. Now, another kind of curious subject, Ed. All we read about is fatigue, that the employees are doing everything they can, but they're getting tired.
Yeah.
They're being pushed. What's management's view on this? I mean, I can read in the paper, but I'd like to know what you see, because you're there.
Yeah, and I know what you're alluding to, Al. First of all, I think the duration and the intensity of this pandemic has been incredible, and it's been taxing on everybody. We don't talk about it a lot, but if you think about the stockroom personnel here at the hospital, materials management, trying, to compete with the supply chain that just doesn't have enough supplies, and how hard they're working. You think about our laboratory in terms of they've been turned upside down. I mean, everything is about testing, and in trying to make that happen. And it's all in the interest of safety of our patients and our staff. You think about the housekeeping department in terms of what it's meant to them, in terms of cleaning throughout the hospital. And certainly our physicians, as we've talked about a little bit today, and our nurses. And the word we hear a lot is everybody is exhausted. Their life has changed at the hospital, in the physician practices, and at home. And everybody is scared, and they want to kind of move on. And the good news is that there is light at the end of the tunnel. Now, we the headline recently is that our nurses are exhausted, and we feel very fortunate in terms of the nurses that we have at Milford Regional. They're the individuals that spend the most time with patients day to day. They're gowned up the most during this pandemic, and they're really living COVID day to day. And in speaking to them, it's not only about the workload, but it's the fear factor in terms of what it means for them and their family. And certainly, again, light is at the end of the tunnel. Now, recently, what's been in the paper is that the Mass Nurses Association is trying to organize our nurses. And so that's a process that's just happened during the most difficult time of a pandemic. I think, it's a challenging time to sort out what are pandemic issues versus other working condition issues. And our goal in terms of working with our nurses is to make sure that there is going to be a vote here. The date has not been determined. And we at Milford Regional want to make sure that our nurses are as informed as possible. Milford Regional has been a special place. As we've talked tonight, it's got a special feel. It's got a family feel. People come to Milford because of its environment and the feel of the place. We want that to continue to the best of our ability. And again, we respect our nurses. Some of the claims by the M&A, have to do with issues like PPE, so supplies, testing, outbreaks and things like that, and things that wouldn't happen in a unionized hospital. We want our nurses to get the facts. And again, we don't want to be point counterpoint in the public. But some of what's been reported. So we did have an outbreak of staff on one of our units, but frankly, virtually every other hospital, and particularly unionized hospitals and some of the bigger ones, have had the same. The M&A does not have supplies. They're not a supply chain. They can't provide us testing. But these are all real issues of the pandemic. And again, our goal is to support our nurses, whatever they decide. We just want to make sure that they're as informed as possible. Many of our nurses work here because we're not a unionized hospital. And many of our nurses have never worked in a unionized environment. And again, our goal is to have a good educational process to make sure that they're informed, and whatever they decide, we'll honor. And ideally, we'd like to keep the culture that we have at Milford Regional the same as it is for our future.
But Ed, I guess what I'm confused on is a lot of the information I see is that hospital management is putting profit ahead of safety, and hospital management isn't buying enough PPE. But I look at the references, they're from large for-profit hospital centers. Does that really apply to our medical center?
Again, Al, a lot of what's in the paper is pandemic specific. So the challenges that Peter mentioned in the beginning, that in the beginning, we were conserving masks for healthcare institutions because there just wasn't enough to go around. Testing has been an ongoing challenge. Not to say that these issues are everywhere and it's okay, because we're all working to improve them. We want a safe staff. We want our patients to be safe. But a lot of the issues that are in the paper right now really are pandemic related and things that are outside of controls and matters that really all hospitals are struggling with.
If I look you straight in the eye and say, are you doing the best you can for your employees? How would you answer?
I would say that we're doing the best we can, but we can always do better. And we're striving to do better.
And that's all we can ask. It's the same thing when I asked you, you give me the best medical care you can.
It's the same answer.
Same answer. Peter, now you take up the mantle. It's now on you to make it one, it's no longer 4 doctors taking care of the whole town. Now you've got 100, and I'm still amazed at how, Patrick, you recruited during the pandemic, especially primary care physicians, because nobody can get them or keep them. But I always look at the medical center as a special place. Because, when you meet people and they say, well, I've only been here 15, 20 years. That's a statement. When my mom got cancer and she had the same oncologist for 15 years, that made her much more comfortable and easier to maintain her compliance. So whatever we've been doing, Ed, keep doing it. Peter, you got big shoes to fill now. Same with Patrick. You got to keep the physicians we have and keep bringing in new ones. But we'll always tell you what you're not doing right, especially in the medical field. We all have opinions because we're trained medical professionals. Yes. But overall, thank you for everything you've done. And please keep doing it because we need you.
Thank you, Al. That really means a lot to us.
Yeah, we're a team at Milford Regional, so everyone in our system participates in the success of Milford Regional. So we're grateful for everyone's efforts, and we pledge to do the best we can to serve our community. So thank you, Al.
And we see construction going on next to the hospital, so good sign that things are even going to get bigger and better. I know you won't tell us.
You mean across the street?
Yes.
Yeah, no, that's part of the intersection expansion. So it's actually land that we own, but it's not construction that's going up yet, though. That I think that is a natural impression. So we have not figured out a purpose for that property yet, but no doubt, based on our history, it won't be long.
Well, thank you again, and to our 6 loyal viewers. May God bless. May tomorrow be a safer and just a better day. 2020 was a challenge for our medical staff, for our families. I mean, for the first time, my darling bride didn't cook a Boeing for Thanksgiving. We had 6 people, just our immediate family, but we got through it. And if we do as Dr. Peter said, and behave ourselves, when the vaccines come that Dr. McSweeney mentioned, we'll be here waiting for them. So good night, all. Thank you.
Not too long since I've been home. Been running all my life just